Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
This program is presented by Medscape Education Global.
Hello, I'm Riley Beauvais, Associate Professor of Neurology at the University of California, San Francisco. Welcome to this program titled New Considerations in Managing Family Planning in MS. This program consists of 5 short segments. Segment 1, with Ruth Dobson, will cover the patient perspective on pregnancy in MS, and will include an interview with a patient showcasing her views regarding her MS and pregnancy. Segment 2, with Sandra Vukusic, will focus on the mother throughout the pregnancy journey. Segment 3, with Kristen Helwig, will focus on the baby, making evidence-based choices peri-pregnancy. Segment 4, with Annika Vandervelt, will focus on holistic care considerations along the pregnancy journey. And the last segment that I'll present will focus on optimizing outcomes in pregnancy and MS.
Thank you for joining us for this series. My name's Ruth Dobson. I'm a Professor of Clinical Neurology at Barts in the London and Queen Mary University London. And welcome to this section of the programme, focusing on the patient perspective on pregnancy and MS. I'm joined today by Manisha Chandrana. So Manisha, do you want to introduce yourself?
Hi, yes, I'm Manisha. I'm 45 years old. I was diagnosed with MS in 2011 when I was 32, and I have a daughter who is 5 years old.
Brilliant. So thank you so much for joining us, Manisha. And just to give a brief introduction to this session, family planning is such an important topic for many people with MS, but it involves a real weighing up of risks and benefits. In my clinical experience, people with MS come in and they worry about the effects of disease modification on their child, the effects of taking drugs either prior to or during pregnancy. They also worry about having a relapse during pregnancy or postpartum, and the effects of disability in terms of their ability and long-term care for their children. On the other hand, people worry about the effects of stopping disease-modifying therapies. They might think, well, that might make a relapse more likely. And weighing all these things up is really hard, and it's really different for every single person. As neurologists, we give advice, but often we give inconsistent advice, both within ourselves and also between different neurologists. And this is some work that I did a couple of years ago now, really trying to look at this in a bit of detail. So we asked a number of neurologists across the UK what advice they give to patients treated with natalizumab who are considering pregnancy. And as you can see, that the advice given really ranged across different advices right through from stopping natalizumab prior to conception to continuing all the way through pregnancy. Whilst this may not be an issue on an individual patient basis, we now live in a world of social media, and of course people go online, they share what they've been told, they share advice, they share stories. And so patients come back really not trusting and not knowing who to believe around this. Luckily, over the past few years, things have moved forward. We've developed international consensus guidelines that really help to inform neurologists about the discussions they should be having with patients, how to frame these discussions, and how to help weigh up risks and benefits of treatment, stopping treatment and other approaches in multiple sclerosis. But for this session, what I really wanted to do is explore with Manisha some of her views and some of her reflections on talking to lots of women with multiple sclerosis and pregnancy. Manisha and I have known each other for a long time, and she's been an absolutely brilliant advocate for many women with multiple sclerosis, approaching going through or subsequent to pregnancy. So Manisha, I just wanted to explore with you, what are some of the challenges around balancing disease-modifying therapy and pregnancy, both from your perspective and also from those of other women that you've sort of spoken to during this time?
Yeah, so I think it's really important to remember, first of all, that pregnancy isn't just the 9 months that you're carrying a baby, but also includes that time for conception. And for some women, that can be really quick, but for others, it can take months or sometimes several years before they conceive. So that conversation about the DMT that you're on really needs to start at the stage that you're thinking about conceiving. Um, Side effects need to be discussed. The delivery method needs to be discussed, especially for women who are going through fertility treatments, for example, or who is taking a long time to conceive. Um, they may not want to have another drug which they have to inject, for example, if they're having hormone injections, or they may not want to go into a hospital and have an infusion if they're going in already for several invasive procedures for fertility treatment. Um, Even if you're trying to conceive naturally, if your DMT has side effects, for example, which don't make you feel great, that can also have an impact on how and when you try and conceive. It might be a case as well, actually, my ovulation period is coinciding at the same time as I need to take this DMT, and I'm not going to feel great, and I really don't want to go through with this. All those factors have an impact. And it's really important that I think clinicians recognize that, and they don't just see the DMT as being this is a DMT, this is the percentage risk of reducing your relapses. Obviously, it has to be taken into consideration as well in terms of how active the NS is. It's a balance. It really is. It's a balancing game.
Yeah, and I think there's something that you touched on there that's really important around uncertainty. Like MS is really uncertain. You don't know if you're going to have a relapse. You don't know what your relapse is going to be like. You don't know when your body's going to let you down next. And also conception is a real uncertainty. And I think until you sort of go through it, you can think, oh, well, I'll just try and conceive and then it will happen and everything will be great. And it's obviously not like that for anyone really, or for the overwhelming majority of people. And I think a real area of uncertainty actually is around postpartum relapses. And I think as clinicians, this is something that we worry about. And I fully hear you about, we like to give facts and figures rather than sort of engage with the emotional aspect of uncertainty. But how did you feel during pregnancy, and how have others felt during pregnancy around postpartum relapses?
Yeah, so I agree with you there that I think neurologists in general tend to give patients a lot of facts and figures um, about relapse rate and the risk on postpartum, etc., and don't actually see the emotional side of it. They don't see that a woman may be feeling very scared and very worried, and that to a certain extent, sometimes it doesn't work just throwing figures at them, to be honest. Um, it's important to emphasize that MS is a snowflake disease. What one woman's experience is not going to be the same as another. And unfortunately, what tends to happen is women come out of their neurologist appointment with these facts and figures, and then they go to social media and say, well, what happened to you? And what happened to you? And is that going to happen to me? Um, for me, the best thing that happened was my obstetrician and my neurologist, in conjunction with myself and my husband, we came up with a plan of what would happen if I had a relapse during pregnancy and if I had a relapse postpartum. We drew that up at a time where I felt I was capable to make those decisions. We had a plan in place. All we had to do was press the go button if a relapse was to happen. That gave me the best reassurance, I think, throughout the pregnancy and postpartum, because I wasn't having to make those important decisions when I had a screaming baby, when I was sleep deprived, when I was going through those roller coaster of emotions that is postpartum. Um, yeah, I think that for me was probably the best thing in terms of the postpartum period. I already had that plan I had that well in advance.
Yeah, I think that's so key, isn't it? The postpartum period is hard. It's really hard. Even without MS, it's
Yeah.
hard. With MS, it's extra hard. And then if you have a relapse, trying to make that plan at that point, it's impossibly hard. So I think it's about being prepared, having those conversations, and about good communication. And I think my reflection as a neurologist is often we don't do a lot to support communication, particularly where obstetricians may be in a different hospital from us, and then primary healthcare or community healthcare is distinct. And actually often patients feel like they are having to do all of that admin between their team. I don't know if that reflects your experience at all.
Yeah, so I was very lucky. My obstetrician and my neurologist they were in the same hospital. My neurologist actually visited me after I gave birth, which was amazing. So I was lucky in that it was easy to share information. The computer systems were the same. They copied each other on test results, etc. But I know I am the exception. The vast majority of women feel like they are having to lug around a LibreArch file worth of medical notes. If they don't get to see the same doctor every time, they feel like they have to explain their medical history over and over again. They do feel like they are the managers of their healthcare. And I think because of that, often the support that that women need often goes amiss. Um, I tend to find that, generally speaking to other women, um, doctors tend to be very laser focused in terms of their own discipline, and they don't look holistically at the whole person. Um, so, for example, mental health can get missed. That's really important in the postpartum period, generally, anyway, for anybody even without MS. Um, but it tends to sometimes I think women feel like it get things like that get missed because the doctors are only focusing on their area and they're thinking, well, somebody else is looking after that. And also, um, again, the support that's available for women in that postpartum period, women often are not aware of it because, again, um, doctors and MS nurses, etc., are only really focusing on that part of that person and not on the whole person themselves.
Yeah, and I think that focus on the whole person and the pregnancy, not just the MS, is so crucial and such a crucial takeaway, actually. And I think, as neurologists, it's really important that we think about benefits and risks of disease modifying therapy and pregnancy, but also think about the wider patient and the fact that, they have a pregnancy experience as well. And, also these conversations can be really hard with patients. They can be uncomfortable, but actually as physicians, we have a responsibility to open up those conversations, to initiate them, to get people talking about this within the clinic appointment. So I'd like to thank you, Manisha, for your presence with us on this programme and also for all of those insights you've brought, both from your own experience and actually from the wider community of women with MS. And thank you all to the audience for participating, and please continue on to the next section, learning about focusing on the mother with MS throughout the pregnancy journey with Professor Sandra Vukusic.
My name is Sandra Vukusic. I'm professor of neurology in Lyon, France, and in the following minutes, I will focus on the mother with MS throughout the pregnancy journey. In this segment, we will discuss 3 points. Is there a better timing to planning pregnancy in a woman with MS? How can healthcare professionals help women cope with motherhood and MS management? And beyond MS, are there more peripartum mood disorders in women with MS? For many years, women have been discouraged from having being mothers because of a fear that the disease might be worsened during this period. Since the PRIM study in 1998, we know that in general there is a protective effect of pregnancy with a rebound in the postpartum, and at that time, around 30% of the patient experienced a relapse in the first months after delivery. In parallel, we also know from MRI study that there is an increase in the MRI activity, especially in these 3 postpartum period, which very nicely correlates to the clinical outcomes. To define the better timing, it's important to know if there are predictors of relapses. So in the PRIM study, it was the natural history of multiple sclerosis because at that time we didn't have any DMT. And we showed that the risk of relapses in the postpartum correlated with the number of relapses in the pre-pregnancy year and the number of relapses during pregnancy. It means the higher the disease activity, the higher the risk of rebound in the postpartum. In the treatment era, now that we have a lot of DMTs, the risk of postpartum relapses is much lower, around 50%. And if we try to define the predictors of those relapses, there is still this relapse activity in the pre-pregnancy year, but we also know that women with a higher EDSS score, an age younger than 35 years, the absence of DMTs that can control a disease in the pre-pregnancy year and the absence of exclusive breastfeeding are associated with an increased risk of postpartum relapses. There is also an important point on discontinuation some DMTs that are anti-trafficking drugs, such as natalizumab and fingolimod. You can see the evolution of the risk of relapses while using in women using different kinds of highly active DMTs. And you see that when you stop fingolimod, which is the yellow one, there is a rebound of disease activity during pregnancy and in the postpartum. And when you use natalizumab, you usually can continue the drug until the end of the second trimester of pregnancy, and then you have a good control during pregnancy and an increase potentially in the postpartum. And compared to using anti-CD20s, when you see that whatever the drug, the risk of relapses during pregnancy and in the postpartum remains very low, which is maybe one of the best options we currently have. In France, we tried to determine this better timing, and we made recommendation in 2022. And our recommendation was to favor a period of inactivity of the disease for at least 12 months because it's data driven. We had those data on the pre-pregnancy relapses. So in practice, if I try to summarize, the first message is that we should not delay the DMT start in women planning a pregnancy, and we should not stop DMTs too early before pregnancy start, and that is to avoid therapeutic inertia in women that are contemplating a pregnancy. We also should consider switching to more convenient DMTs option to better mitigate risk to the pregnancy fetus versus the risk to the mother. For natalizumab, we can continue until the end of the second trimester of pregnancy and resume it very early after birth, immediately in the first week. For fingolimod and other S1P modulators, we definitely have to stop it before pregnancy start because of an increased risk of congenital malformation. And we should always switch to another high efficacy DMT such as natalizumab and anti-CD20s. With highly active DMTs such as natalizumab and anti-CD20s, they have a shorter delay of action, and then probably pregnancy could be considered earlier than 12 months, around 6 months after treatment onset, if you have the proof that the disease control has been achieved. The second point is how can healthcare professionals help women cope with motherhood and MS management? And MS women have a lot of questions before they can allow themselves having a child. This was summarized in a very nice paper from the Lancet Neurology in 2023. So the key message is really to anticipate and inform the patients, the partner of the patient, and also the other healthcare professional. The first point is to discuss DMT choice considering the family planning. And again, we should not delay DMT due to pregnancy desire. The second important point is that we should, before trying to conceive, discuss individuals' risk-benefit around DMT continuation or discontinuation and decide when to stop. During pregnancy, it's very important at the end to discuss the plans for postpartum DMT resumption and for breastfeeding. There are other questions that the patient do have, not only about pregnancy. The first one is the risk of MS in their child. And you have to mention that the risk is very low, around 2 to 3% lifelong. The other point that is also very important is that pregnancy in a woman with MS is normal, is not different from a pregnancy in the general population. There are no more complications and the outcomes are the same. It's exactly the same for the mode of delivery and the anesthetic consideration, and everything that can be proposed to a normal in general population can be proposed to a woman with MS. So in practice, I would advise to propose to the patient pregnancy counseling specific consultation before pregnancy and once it has started, because it's very useful, again, to anticipate and inform the patient. Also consider informing healthcare professionals involved in pregnancy management, such as obstetrician, midwives, and anesthesiologists, because they don't know a lot usually about multiple sclerosis. And a final point about dedicated educational programs on pregnancy that are currently developed, especially in France, where you can discuss all the questions around management of GMTs and symptoms and so on, but also how to deal with coming back at home with a small baby when you are a mother with MS, with a lot of fatigue and other neurological symptoms. A last point about peripartum mood disorders, and I must say that we are really lacking data on that topic. I found it in the literature 3 cohort studies and 2 prospective studies. What we can say from the cohort studies using linked health databases is that it seems that there is a little increase in the risk of depression and anxiety in women with MS, also in males with MS when they have a children. And maybe this increase is a little bit more important in the 3rd trimester of postpartum. In the observational studies that have been done in the United States, they try to correlate the risk of peripartum depression with different kinds of predictors. And they showed that what can predict the fact that a woman can be more susceptible to have a depression is an increased maternal age, primiparity, but especially pre-pregnancy depression. By contrast, none of the MS-related factors, such as disease duration, the use of DMT, the presence of relapses, or MRI activity, correlates to the risk of peripartum depression. So I thank you very much for your participation, and I advise you to continue on to the next session about focus on the baby, making evidence-based choices peri-pregnancy with Kerstin Helwig from Germany.
Hello, everybody. My name is Kerstin Helwig. I'm a senior consultant of neurology from Germany, and it's my pleasure today to give this talk and focus on the baby, making evidence-based choice peri-pregnancy in women with multiple sclerosis. And the outline of this segment is to present you the latest data on pregnancy-related complications across DMTs, also the latest data about which DMTs are found in breast milk and impact on child growth and development and well-being, and reminder, of course, of the benefits of breastfeeding, but also respecting patient choice regarding breastfeeding. So if we look on concerns women have, there are concerns in women with multiple sclerosis on the health of the unborn child. So this is an important consideration which we have to discuss with our patients with multiple sclerosis when they became pregnant, especially because it takes about 30 years to determine the reproductive safety of drugs. And this is mainly because we need many exposed pregnancies, at least around 300 exposed pregnancies, because the outcomes we are dealing with are normally rare. And this is, of course, for our injectables, which we have since about 35 years on the market. We do have the largest body of evidence that they are safe, that they are unlikely to pass the placental barrier. They are last molecules. They can be continued until a pregnancy testing is positive. They also could be considered to be continued during pregnancy. But here, even with the label update we got a couple of years ago from the interference, there is limited experience with exposure during the 2nd and 3rd trimester of pregnancy. Dimethylfumarate is a good example that it can be faster And in last year, in January, the first data from the Tecfidera pregnancy registry were published in Multiple Sclerosis, analyzing nearly 400 pregnancies without any increase of adverse pregnancy outcomes as spontaneous abortions, major malformations, or stillbirth or preterm birth in these quite large cohort of patients which were collected only in 10 years. So this means DMF and DRF can be continued until a pregnancy test is positive and then be stopped. Beyond the first trimester of pregnancy, there are nearly no data available. We do have other drugs which should be stopped before a pregnancy is planned. And this is especially true for the S1Ps. Here we got a Dear Doctor's letter for fingolimod with an increase in the risk of major congenital malformations, which is about doubled as compared to the natural prevalence of major malformations. And this is why all S1Ps have a class label in Europe. Although it was only shown, teratogenicity was only shown for fingolimod so far. We do not have enough data for newer S1Ps, but still, according to their half-life times, they must be stopped. Fingolimod 2 months prior to pregnancy, siponimod only 10 days because it has a very short half-life time, ozanimod 3 months, and punizimod also with a very short half-life time, 1 week before planned conception. It is important to notice that there is a relapse risk when we stop these drugs, and this is why we should use potent alternatives for women planning a pregnancy, and these could be anti-CD20 antibodies, cladribine, or natalizumab, but only if natalizumab is being continued, as it is also associated with the risk of relapses if it is withdrawn during pregnancy. We recently got new data from the MAPLE study. MAPLE study is a pharmacovigilance study on the use of Mavenclad in pregnant women with multiple sclerosis. And here, about 336 pregnancies collected with 157 known outcomes. And so far, there was only one major malformation, translating to a risk of prevalence of 1.1%, which is so far not elevated. And also the other pregnancy outcomes were in the normal range, with spontaneous abortions at the higher edge of the normal range with 20%. So this does not mean women should plan a pregnancy before the recommended 6 months. But if a pregnancy occurs, then panicking on elective termination per se is not necessary, as we get more and more exposed pregnancies with a so far normal risk of major malformations. We then have the huge drug class of monoclonal antibodies, which are large molecules, and they are unlikely to cross the placental barrier in the first trimester. Normally, they have a half-life time between 14 and 30 days. Because they do not cross the placental barrier, they are unlikely to be teratogenic. Theoretically, they could interfere with implantation. This is a theoretical risk that, for example, the risk for spontaneous abortions could be increased. It is then important to consider that monoclonal antibodies will start to cross the placental barrier from the second trimester on, with an increasing transport up to delivery, and then biological effects in the newborns are possible. Depleting antibodies seem to have a much longer biological effect than the drug is detectable in the blood. And for alemtuzumab, which is not much more used in the treatment of multiple sclerosis. A pregnancy could be planned 4 months after the last infusion. About the anti-CD20 antibodies, I will talk more in detail, as I will do with natalizumab. So I already said that there is a risk of rebound if we stop natalizumab. This is why, in general, natalizumab is recommended to be continued until gestational week between 30 and 34, and then it is needed to be restarted early, which means in the first 2 weeks postpartum. So this approach minimizes the relapse risk during pregnancy and postpartum, but the newborns might have reversible hematological abnormalities in the first 3 months, and this is mainly anemia and thrombocytopenia. And in total, if you treat until the 3rd trimester of pregnancy, the risk for hematological abnormalities is about 70%. We then have the group of the anti-CD20 antibodies with ublituximab, ofatumumab, ocrelizumab, of course, and rituximab with different pregnancy labels. I would like to point out that the label of ocrelizumab was recently, in January 2025, changed from avoiding the drug 12 months prior to pregnancy to 4 months prior to pregnancy. And this is because there is an enormous amount of safety data being collected since the drug was approved. And we do not see any negative impact on the most important pregnancy outcomes if pregnancies were exposed to ocrelizumab. So again, spontaneous abortion, stillbirth, preterm birth, major malformations are in the range of what is going to be expected. I would like to talk about monoclonal antibodies. So and present you the Sopranino study, which was presented first at the ECTRIMS meeting last fall. So here, mothers received ocrelizumab as an infusion during breastfeeding, and we followed 13 newborns, and ocrelizumab levels were negligible in the breast milk, and of more importance, it was undetectable in the infant serum, and again, the B cells of the baby, even though they were breastfed under ocrelizumab, were in the normal range. And from our group, we presented last year in Denver at the AAN meeting data on breastfed infants, 183 breastfed infants matched for monoclonal antibody exposure at the beginning of pregnancy, and we did not see any increase in hospitalization, systemic antibiotic use, development delays, or any change in growth parameters between those groups. So this means that breastfeeding under monoclonal antibodies seems to be generally safe. And I personally believe that this will change in the next future, that in a very few couple of years, all our women with multiple sclerosis can be safely advised, if they want to, and that's the important message, that they can breastfeed under monoclonal antibody treatment. And then I would also like to present the Minori study, where 35 women received ocrelizumab prior to pregnancy, in the 6 months prior to pregnancy or in the first trimester. And then ocrelizumab was measured in the cord blood of the baby and also only detected in 2 babies, and not detectable anymore except in 1 baby at the age of 6 weeks in the baby. And even more important, the B cells were absolutely in the normal range in all the baby, meaning that the drug had no biological effect. I would like to come to the last part of my talk, and would like to talk about breastfeeding. So breastfeeding is something which is recommended by the World Health Organization and each national health organization because it has benefits to the infant and the mother. So it decreases the risk of infection for certain diseases. And of course, it's good for the bonding, and it can decrease the postpartum hemorrhage and also breast and ovarian cancer in the mother. So we do have some drugs which are approved during breastfeeding, mainly our injectables, interferon beta and glatiramer acetate. We do have monoclonal antibodies, which are partly approved during breastfeeding. And we have oral drugs, which label for cladribine with the last cladribine intake 1 week before women should start to breastfeed, and a relative infant dose in 2 women of 3%. We do have some measurements to start with the orals first on dimethyl fumarate with a very low relative infant dose of 0.007 to 0.019%. This is really low. A relative infant dose below 10% is considered to be acceptable during breastfeeding. And there are also a few babies which were breastfed under the treatment with DMF. So it's not fully advised yet, but first agencies, teratological information services start to say in mature newborns it could be acceptable to be breastfed under these drugs. And by this, I would like to thank you for your participation. Please continue on to the next section about holistic care consideration along the pregnancy journey with Anneke van der Wald. Thank you.
Hello, my name is Anneke van der Walt. I am a neurologist and MS specialist in Melbourne, Australia at Alfred Health, and I also work at Monash University in the School of Translational Medicine. In this section, we are going to talk about general consideration and holistic care along the pregnancy journey. A number of topics will be covered around the general planning for pregnancy and preventative health. So what should be considered before conception, especially around disease-modifying therapies and the planning relating to these? The key point here, and you may have heard this already, is that family planning considerations need to start years before the actual conception and pregnancy and should be part of the discussion around any treatment decision for women of childbearing age. The choice of disease-modifying therapy should consider the possibility of a pregnancy in the foreseeable future, and it's really important that the patient is informed around the safety of their particular choice, whether a change may be needed throughout their disease course before they start actively trying to conceive, and also around the risks related to unplanned pregnancies and the need for contraception. It is also important to think around preventative health, and here I'm specifically thinking about vaccinations. Again, this should be considered before the initiation of any disease-modifying therapy. For women of childbearing health in particular, it's important to make sure that there is immunity against rubella, because once a patient is on disease-modifying therapy, a live vaccine such as that for measles, mumps, and rubella would be contraindicated. So if disease activity allows, then the patient should be vaccinated before they receive a disease-modifying therapy. However, in most cases, a delay is not desirable, and the patient will be already on a disease-modifying therapy or pregnant. In this case, inactivated vaccines can be administered safely, and they should be updated according to the local guidelines. The usual initiation and timely initiation of folic acid at least 3 months before conception should be advised, and adequate vitamin D supplementation is important. It's also important at this point to update cervical precancer screening and discuss sexual dysfunction and health because these can impact on conception rates as well. What about symptomatic management? Fatigue, bladder, bowel symptoms, these can all flare up and may worsen during pregnancy, and many of the symptomatic therapies that we would usually use will be contraindicated in pregnancy. Again, planning is essential. We need to do a detailed review of all the tablets that the patient might be taking in the planning phase of the pregnancy, minimize doses, avoid polypharmacy, and make choices towards drugs that have the most pregnancy data available. It is also important to implement and think around alternative strategies to manage symptoms, like physical therapy, for instance, and to emphasize the importance of a healthy, balanced lifestyle, diet, exercise, and also the development of a support network. I'm going to briefly touch on the use of assisted reproductive techniques. Although fertility is not affected by MS, of course, infertility occurs and ART may be needed. Most recent studies have demonstrated that there is actually no concern around an increased risk of MS activity or relapses after ART. And the guidelines would now suggest that women with MS can safely pursue ART without increasing their relapse risks. What is the benefits of pregnancy in people with MS? In general, pregnancy is a time when relapses decrease, and this is particularly true towards the end of the second trimester and the beginning of the third trimester, with an increase in relapse rates postpartum. We also know that pregnancy can delay the onset of clinically isolated syndromes, and this is data that has been published from large observational studies that demonstrated that women who have had a pregnancy have a delay of their first MS symptoms by about 3.3 years. The benefits on disability progression is, however, less clear. Fortunately, most studies will demonstrate that there's no worsening of neurological disability following pregnancy. However, the effect of pregnancy in actually preventing disability accumulation or progressive MS is less clear. It is also unclear what the effect is of pregnancy in women with progressive MS and those who conceive with already at a higher EDSS score. How do we reduce risk of relapses then during and after pregnancy? The key factor here is disease control before pregnancy, and particularly in the 12 months before conception. We know from multiple studies that risk factors that increase relapse rate would include a higher relapse rate in the 12 months before pregnancy, as well as new or contrast-enhancing MRI lesions in younger patients, and also in those with a higher EDSS score, and those who withdraw natalizumab or fingolimod before pregnancy. It is important that DMTs are recommenced early after delivery, and that this forms part of the discussion before delivery and before delivery, so the decisions are in place. If someone does have a relapse during pregnancy, we would often observe, but with more significant relapses, this needs to be treated with corticosteroids, usually methylprednisolone, as by a standard protocol. Any relapse that is more severe can be escalated to be treated with plasma exchange, as this has been shown to be safe in pregnancy as well. The concern around first trimester exposure to corticosteroids has largely been put to rest, with data from over 10 years of follow-up demonstrated no association of cleft palate and corticosteroid exposure in first trimesters in humans. Relapses due to withdrawal of fingolimod or natalizumab can be very severe and potentially life-threatening, and should also be actively managed. Breastfeeding and postpartum risk is important to consider as well. Studies have found that breastfeeding, particularly exclusive breastfeeding in the first 6 months, reduced the risk of postpartum relapses by 67%. This is not the case with non-exclusive breastfeeding. Largely, however, this protective effect is lost at 6 months postpartum. Mothers should be encouraged to breastfeed, but again, this needs to be balanced against the needs and the specific preferences of the mother to avoid any undue pressure. The mode of delivery and anesthesia for women with MS is again difficult to study. We do know that women with MS have a higher rate of labor induction and assisted deliveries. And this is quite likely because of a bias around a woman with MS being potentially more fatigued or may have pre-existing disability. Adverse neonatal outcomes are not increased in women with MS. And MS pregnancy should not automatically be considered high risk. And here it is important that the MS clinician advocates for their patients and inform obstetricians of this. It is also important that the patient is encouraged to advocate for themselves. In conclusion, reassurance that most pregnancies in women with MS are no different from those in women without MS is important to provide throughout the pregnancy and also in the family planning preconception stage. Start this early and focus on controlling the disease activity as best as possible in the 12 months prior to conception. That brings us to the end of this section. Thank you for your participation, and please continue on to the last section about optimizing outcomes in pregnancy in MS by Professor Riley Bove.
And welcome to the last segment of this program entitled Optimizing Outcomes in Pregnancy in MS. This is me again, Riley Bove, from the University of California, San Francisco. So I'll be presenting a case. This is Leticia, a 26-year-old recent graduate from a master's program in education who is seen in our MS clinic for follow-up from a recent hospitalization. So Leticia had presented to urgent care with visual blurring in her right eye. She was referred to the emergency room, where a brain MRI revealed an enhancing optic nerve lesion, as well as other enhancing and non-enhancing lesions in locations consistent with MS. She is seen to confirm her diagnosis and establish care. Altogether, she fulfills McDonald criteria for MS, and initiation of disease-modifying therapy is advised. At this time, Leticia is single. She's recently started her first job postgraduate. She does not have any childbearing plans in the coming years. So the conversation here should involve reassurance that she will be able to have the family she would otherwise have wanted to have, in most cases. This makes her parents, who have accompanied her to her appointment, tear up with the reassurance. Conversation should also involve counseling regarding the importance of pregnancy planning and prevention, and establishing expectations that we will need to revisit this at each visit over time, since circumstances and plans can change. Discussion of the risks and benefits of medications surrounding childbearing, and set the stage that this is always a shared decision-making between the patient, their loved ones, and the clinical team. Since she is not planning a pregnancy, the conversation should involve a device on use of reliable forms of contraception, such as IUDs, oral contraceptives, and others. Leticia chooses to begin a B-cell depleting therapy after completing her HPV vaccination series, which she had not received as a teen. She does not experience any new relapses in the coming years, and scans obtained after her first 6 months on therapy reveal no further lesions. She does endure some depression and starts an antidepressant. Over the coming years, during her routine visits, there is brief counseling to assess her relationship status, her plans for childbearing. She does date a few men over the years, but no relationship passes the threshold of seriousness and commitment. So you make sure at each visit that she is using reliable contraception. After about 3 years, Leticia comes to clinic with a partner whom she is seriously involved with, and together she and her partner ask about pregnancy considerations. This is when you advise them that overall, there are no major differences in the risk of adverse pregnancy outcomes associated with MS. Furthermore, you expect that the relapse risk may be well controlled with her B-cell depleting therapy. You advise that she could plan to conceive 2 to 3 months after her infusion based on PK/PD data. And this would ensure that by the time the medication could cross the placenta at the end of the first trimester, there would be no medication in her bloodstream left. You advise that she let you know when she is planning to conceive, and until then, she should continue her contraception. You obtained a pre-pregnancy baseline MRI against which you could compare any changes during pregnancy or postpartum. And you also review her general wellness goals before pregnancy, including exercise, taking folate and vitamin D, and making sure that she is on an antidepressant that her OBGYN considers compatible with pregnancy. Letitia begins conception attempts 3 months after her last infusion. 3 months later, she is not pregnant and would be due for her 6-month infusion. You review her options with her, which include to continue conception attempts and monitor her B cell levels, or to schedule her infusion, use barrier methods for 3 months, and resume conception attempts. She decides to continue conception attempts, trending her B cell levels every 4 to 6 weeks. You also let Letitia know that after about 6 months of conception attempts, you might consider sending her to a fertility specialist, not because she has infertility, but for an initial evaluation to optimize her chances of conception off DMT. The next month, Letitia does become pregnant. You hold all further infusions and offer to speak with her gynecologist to align on her pregnancy plan. You make sure to schedule a 7-month pregnancy visit to review Letitia's function, her plan for delivery, and her postpartum course. The 7-month visit should include counseling about social support and emotional support postpartum, since there is an elevated risk of peripartum depression. Review the delivery plan, ensuring that there are no neurologic-specific guidance regarding her delivery plan. It's really the obstetric requirements that guide the plan. Advise that she seek early lactation support if breastfeeding is planned. And document your note quite extensively so that Letitia can carry this between the different clinicians who may be participating in her pregnancy management and care. You also maybe engage her partner in helping her to navigate familial expectations and new roles surrounding parenting. You schedule a visit 1 to 2 months postpartum to review Letitia's wellness, MRI, and needs, including mental health needs and rehabilitation needs. Scheduling this postpartum visit while Letitia is still pregnant can help make sure that she is able to tee up everything she needs to do before the delivery. Letitia delivers a healthy baby boy at 38 weeks. She has a scheduled infusion 2 weeks postpartum. Her postpartum MRI reveals no new lesions. She does experience some peripartum blues, and you increase her antidepressant dose. You also speak with her and her partner again about recalibrating support and expectations of their extended family. Letitia is breastfeeding exclusively, but because of an increase in fatigue and her mood changes, you advise that she try to get 4 to 6 hours of uninterrupted sleep during the night, during which time the breastfeeding can be supplemented by a bottle and formula. So key takeaways to wrap up this program. We have presented to you the latest clinical data on achieving disease stability with medication management before, during, and after pregnancy. We've also presented to you the latest clinical data on risks associated with disease-modifying therapies before, during, and after pregnancy. We reviewed the transfer into breast milk of the disease-modifying therapies, what is known to date, and we've also provided a comprehensive approach to managing MS in pregnancy. We hope this helps you think how to provide proactive, comprehensive care for patients during this important time period in their lives. I'd like to thank my colleagues, Ruth Dobson and her patient Manisha, Annika Vandervelt, Kirsten Helwig, and Sandra Vukusic for their valuable participation. I'd like to thank you for participating in this activity. Please do continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.